welcome to this episode of Synapse. Today with me, I have Dr. Roger Ghoche. He is a practicing palliative care physician since 2010. He began his career in Toronto Western Hospital and Kensington Hospice, and he currently practices at Mount Sinai Hospital, which is affiliated to the McGill University, and he provides care on the inpatient palliative care unit and in people's home. He's an assistant professor at McGill University, and he also holds a master's degree in theological studies from Tyndale University. He's extremely passionate about the physical, emotional, and spiritual needs of his patients. Thank you so much for being here with me today.
Thanks for having me.
So I thought we can start out by, speaking in general and explaining to everybody what end-of-life care is and what palliative care is. Can you maybe start with that?
Yeah, sure. So palliative care, the word palliates to palliate, is to provide comfort or relief. And so it's an area of medicine that takes care of patients with illnesses that are incurable. Now, that's not the only feature. There are many illnesses that are incurable, at least at this time, like diabetes and other things. But this would be a context where the incurable illness is causing significant effects on a person's sort of daily activities and abilities, that disease is progressing, and that disease is likely to lead to death in the foreseeable future. That being said, in some areas of palliative care, you may take care of people who are actually going to get better. So the question of them dying or not is not particularly specific about palliative care as an area of medicine. Typically, it's been known as an area that takes care of people with terminal cancers that have reached the limits of medical care. So there are no more treatments we know of that can treat a particular cancer. But over the last 30 years, it's really grown in areas beyond just cancer. When I was at Toronto Western Hospital, in fact, there wasn't even a cancer program at that particular hospital. Now, part of the network, obviously, Princess Margaret is a cancer hospital, but at that hospital, there was no oncology ward. And so probably about 50% of our cases were non-cancer. Anything from stroke, the Toronto Western was the neuro center in that area. So there was a lot of neurology, stroke, movement disorders. I worked in a palliative movement disorders or Parkinson's disease clinic with a neurologist there. We worked with the hepatologists, and so and that remains true where I'm at now at Mount Sinai, where we take care of yes, many patients who have cancer, but many other illnesses. I even know that back in Toronto, some of the doctors at Toronto General took care of patients before they received lung transplants to palliate their symptoms while they waited for the transplant. And then obviously their patients were cured and didn't need palliative care anymore. So the palliate part is really the core part, I think. It's sort of like how do you provide comfort? What can medicine offer when cure is not possible? And it turns out there's a lot of things we can offer, not just in terms of the doctor's role, but the nurse's role and the whole allied team, which is a core part of what palliative care means, which is that it's a interdisciplinary specialty. So it's always a team. So we work closely with nurses at Mount Sinai, social worker, physiotherapy, occupational therapy, music therapy, art therapy, recreation therapy. I'm forgetting some, to be honest, spiritual care, of course. So, there's so many areas, psychology, and honestly, the possibilities are sort of endless. It can be pet therapy and all sorts of things. So.
Really cool. It's really cool. And I think I just as you were speaking, I noticed that I had even said end of life care, but then I was thinking, as you said, that palliative care is not necessarily equivalent to end of life care. It is part of that care, but as you said, it's a care on its own because it's palliation. And I was wondering if you can maybe hit on the point where at what point do we introduce palliative care, not in patients that may have the incurable diseases and medical condition? At what other point can we start, introducing it to patients who may actually benefit from it without scaring them and making them equate it to, oh, why are they talking about end of life?
Yeah, and that's really a common question and common issue that comes up. Understandably so, doctors are hesitant to make a person more sad or demoralized by bringing up the fact that, oh, this illness is too significant, there's no treatment. Even that term, no treatments, or there's nothing I can do, go see palliative care. It's sort of like we're giving up. And those sort of terms we try to educate to sort of not speak in those ways, because it's not particularly true. There are many things we can do, and just because you can't cure an illness doesn't mean that the person's dying tomorrow morning. They still have a lot of life to live, and medicine should be trying to help them live that life as much as we can. But also, it's just not helpful in terms of trying to get the best care for people if they're afraid of the term even of palliative care. Some areas will use the term supportive care to sort of change the connotation, but personally, I like the idea of palliation, of providing comfort. Another way I like to describe palliative care is it's an area where we use what we know about medicine and the healthcare world to protect people's dignity from the illness. So sort of we're on your side, protecting you from the effects of the illness. And I think patients are very appreciative of our involvement generally. So although it may be hard initially when that referral is made, and even when it's brought up with the patient, when they actually meet the palliative care team, I would say, it's an almost universal sort of acceptance of what we can offer, and the recognition that maybe there's areas that we can help with. So.
Absolutely. And I hope through this discussion, people will start to understand more, because I think even us in healthcare, and I see it and I continue to see it, we have a hesitancy to, oh my God, we have to call palliative care. Like, it doesn't have to have that negative, oh my God, we have to call palliative care. It could be like, I think this patient can benefit from palliative care because it's in their best interest. So I agree. There is a improvement and like a change that we need to make in terms of the perspective we use when we talk about palliative care. And I think a really important thing that you said that I'm going to really keep in mind is the idea of palliation in palliative care, and not, it's just really the support and comfort that we're providing, which is essentially what we're doing as physicians and what we want to do. And I think a question I had in regard to something you said is that, physicians are kind of hesitant themselves to talk about palliative care. And that kind of brought the idea of like death and dying and medicine to my mind. And I was, always thinking about, why are we so reluctant to accept that death is the process, like a process that we're going to have to, face, and it's okay. Like, what, in your opinion, I guess, or from your experience, why do you think that we're so, I guess, fearful of the idea of having patients die?
Yeah, I mean, obviously, it's not a question that we can answer today, but there's certainly a lot of ways of thinking about it that I think can be helpful to explore it in our own lives. I think there's no question that for most people, there are positives in life, and there are things worth living for. Putting aside obviously mental health issues and things like that can lead to other things, but there's no question that for many people, we want to live, and when we're faced with, let's say, a terminal cancer, it's a sad moment to think, oh man, this cancer may lead to my death. So, and obviously that means that, you know, for the most part, we don't want to talk about that every day, which is appropriate. That being said, I think there are a couple of aspects as to why in 2022 it's a particularly sort of stressful topic. I think in 1822, there were people had a much shorter life expectancy. Death was much more common. The death of children was much more common. There wasn't much one could do in the face of illness other than hope that they survive. You know, I had done my project in my master's degree on two plagues that had hit the Roman Empire and that had devastated the Roman Empire. And it was shortly after those plagues that the first hospitals cropped up. They think that the first hospital, you know, basically a building where people would go to be taken care of for their health needs, was started by a wealthy Christian woman about 50 years after the second plague hit the Roman Empire, and it was essentially a palliative care unit, because I mean there was no effective medicine for people who were dying. It was just like, take care of them, get them water, take care of their basic needs, help them eat a little bit, so I think as a species we used to encounter death frequently, and as we know, things tend to be less scary if we see them more often. So like I'm scared of spiders, so the treatment would be that I'm exposed to spiders more and more, and then eventually I would not be scared of spiders anymore. And so it's sort of a similar effect. And I think in 2022 we don't see death. Death happens so predominantly in hospitals, away from the community. Thank goodness, like, children don't die at the same frequency at young ages anymore, so we don't see that anymore. So these are all good things. We live longer, we live healthier, but it does mean that when it comes to the end of our lives, it's something we maybe haven't seen before. We haven't seen a lot of our family go through it, or only in little bits while they were in hospital. And so there's so much unknown that I think that's a big part of the experience of our population these days.
That actually makes a lot of sense, and it's absolutely true. We kind of run away from the things that we don't know, and we fear the things we don't know. I guess, like, based on that, let's say now from a perspective of a healthcare professional who's in hospital and has been seeing the process of patients that are dying, or patients that, not unnecessary care but excessive care, that may be doing more harm to patients than good. How can we as a team, or as an individual physician, or someone who is practicing with patients where I'm uncertain of this, how can I address, or like kind of reflect on how I can assess the situation? When do I get palliative care involved? When can I ask for that help if I'm feeling uncertain about what's going on?
Mm-hmm. Yeah, so going back to the palliate idea, I think if you have someone whose illness is going to be causing long-term symptom issues, the palliative Parkinson's clinic that I mentioned earlier is a good example, where those patients tend to, as their illness is in the later stages, there's much less of the neurological symptoms that predominate, and it's more things like pain, constipation, like salivary things, and stiffness. And so that's an area where the neurologist I worked with, Dr. Miyazaki, was like, these are symptoms that are going to be there for a long time. This is the area of palliative care. I should get them involved, and that clinic was created. And so that can be true in a lot of other contexts. I took care of a woman once whose lymphoma had been cured, but ever since the chemo, she had nausea on a daily basis for 3 years and would vomit, every couple of days from that nausea. And there was no sort of obvious way to deal with this. And she was referred to palliative care. I mean, she wasn't dying; her lymphoma was cured. This was, but we were able to help her because this was palliation of a symptom that was not going away from an illness. So,
like, it's just very interesting to keep in mind that, like, the palliation portion, the palliation of many like illnesses exists, whether it's like terminal illnesses or non-terminal illnesses. Because I know we had spoke like in our classes spoke about how palliation was involved in also cardiovascular diseases, and you wouldn't think, you would, like, when I'm in class or in the hospital and things like that, you see congestive heart failure, you see heart failure, you see people that are going on with their daily lives, but palliative care has a role in that as well. There's a lot of symptoms that cause great discomfort and great discomfort and disturbances in their lives, and their palliative care plays a role in that too. So I think, at least myself, and I think others may be able to relate, that we kind of just need to remind ourselves to expand the way we look at palliative care, that it's not this just one model of like end of life. So it's really just like separating and understanding what palliative care truly is. So I think,
and
sorry,
I'll just mention it, and it doesn't mean that every time you need a palliative care doctor or a team to do all of it, but it does mean that a family doctor would want to have some of those skills. So someone who has chronic nausea, that they have some of those palliative care skills, and that they can apply them sort of within their own practice. So it may be that we still do mostly the complex stuff. But palliation should be part of almost any doctor's sort of toolbox to be able to palliate the things that they can't cure.
And it's just, I think, the importance of recognizing that what you're doing, because I think oftentimes what we end up thinking is, oh, we're just managing the disease, we're treating the disease. So I think just the wording of like, no, we're not curing them of the symptom, but we're palliating what they're experiencing. It's very a different perspective of very much the same situation. So I think just working on how we see things and how we see what we're working with when we're working with patients. And I think just to be a little helpful for people who may be interested in, finding out a little more about palliation, what they can do. And I think just to kind of add into that, having discussions between families. So how can families or loved ones, address palliation? Because I know palliation goes beyond just, palliation of symptoms, but also, let's say, for terminal diseases, there's the whole process of palliative care. How can one address within their families or express what they want if ever they require palliative care? But this would be probably more specific to like terminal diseases, where you would want to have a clear, understanding of what a patient would want.
Yeah, it's a great question, and sometimes that is necessary that patients or families advocate for the involvement of palliative care. I think sometimes in the medical world there's a desire for it to be like a clean switch, like from active medical care to palliative care, and I think one important way to advocate is to say, I understand we're trying to treat this disease, but there's this symptom that is causing so much discomfort. Is there someone who can help with that, that symptom? Would palliative care have a role in helping with that particular symptom, even while we continue to try to treat the disease? That would tend to come up in a lot in like CHF or COPD, where there's breathlessness that maybe is hard to control with the typical disease targeted medications, where palliative care approach might say, well, while you're doing that, while you're maximizing puffers or maximizing CHF management, maybe there's a role for other things to help with their breathlessness, so that they can do a little more on a daily basis. I remember a patient in the Parkinson's clinic who he was actually a retired physician with advanced Parkinson's, and his main quality of life was being able to walk to the local mosque. But it had become really difficult because of his Parkinson's. He would have pain, and so yeah, we were able to, with some opioids, I think we ended up with a fentanyl patch. So it's a patch that would go on the skin. You change it every 3 days, fairly convenient. And he was able to then walk to the mosque and be with the community there when he wanted. So that's palliation. Whether it was me doing it or the family doctor or the neurologist doesn't really matter. But that's thinking of it more in a palliation way, even though it wasn't a disease modifying treatment. It wasn't the Synapse that was adjusted or something like that. It was really a symptom targeted treatment.
And I think a really important thing that you said there that we often forget, at least when we're so concentrated on medicine, is the aspect of how much it can impact their lives, having this symptom that requires palliation, how much that pain prevented him from going to a mosque, which was significant for him, for his life. It gave him meaning, gave him purpose, which ultimately will be one of the most important factors to help him in whatever disease course he's going through. So I think just as people who are in the hospital, as healthcare professionals, we kind of have to remind ourselves, we have to focus on these things that extend beyond what we're comfortable with or what we think needs treating, because ultimately it does have an impact on their recovery, health, well-being, their journey through the disease. So now I was thinking, I guess this kind of tackles both end of life in general and also palliative care. Whether you had experience on it or not, how was your role as a physician in palliative care and end of life impacted by the pandemic, if it was impacted at all?
Mm-hmm. Yeah, it was, the pandemic was sort of an interesting time for palliative care. Obviously, we weren't too much on the front lines. So we were always sort of at our hospital, waiting for our wave or waiting for our outbreak. And certainly we had some, but we didn't end up having any major outbreaks, especially in the first wave. What did change was that there was a lot more need for home care, a lot more requests for people to receive palliative care at home. Probably a combination of not wanting to go to the hospital and catch COVID, but also I remember one person I took care of, her son was working from home, and so he was able to sort of be home and be her caregiver while working, and his employer understood that he would do his best and work, but sometimes he may have to go get medicine for his mom. And so that was a scenario that I don't think she would have been able to die at home if it hadn't been the pandemic context. But it meant that there were a lot more needs for home care. So that was particularly hard on our home care nurse. That was a huge caseload, but it was increased caseload for us as well. Obviously, it's a little bit more time efficient to take care of patients when they're in the hospital than driving to their homes. But it worked out, and we did some of it virtually, which had its challenges, but we sort of adopted often a hybrid where we would do at least one visit at some point, but we would try to gather the bulk of the information virtually, so that we would limit in-person encounters. Otherwise it was a lot of communication. So palliative care, we call families and interact with families a lot already as a specialty, but it was even more during the pandemic because not everyone was able to visit, or people who weren't able to travel to visit their loved ones. So that was definitely a change. All three of us at Mount Sinai, sort of, we were on the phone a lot more than we used to be. But we made it work. Ultimately, I think people understood, like patients and families understood the challenges and sort of adapted to them. Yeah.
Yeah, yeah. Well, it's nice to hear that it didn't, severely impact, and that you guys provided the best care you could, obviously given the context of the pandemic. I was just curious, I guess, based on the experience I've had being in the hospital recently, um, palliative care is becoming, not becoming, or just we're recognizing it more, I should say, that it's the access isn't there, because whether it's the funding isn't there, or we need more resources that are available in the community, or whatever it is. Like, what are your thoughts or opinions in terms of like what needs work? Is it, do we need to continue investing more? Do we need to continue raising awareness on the importance? Is there a lack? Because there seems to be waiting lists and long waits and no beds available, like the typical things that we
Mm.
unfortunately have to experience in healthcare. But this was just me trying to understand what is it that we need to start, addressing to try to help the situation.
Yeah, it's a very good question. I think it's probably complex. Like I do wonder, has epidemiology changed a bit post-pandemic? Are there cancers that are being detected later, or things like that that could be affecting sort of the ebbs and flows of palliative care needs? There's no question that province-wide, countrywide, there is a lack of palliative care resources, not just in terms of dedicated palliative care providers or number of hours being provided to palliative care service, but also in terms of equipping non-palliative care healthcare providers to provide some palliative care. I think there's major gaps there. And that's not just in medicine, that's in nursing and social work, and I think all the healthcare areas. It's not something that I would say Canada has done a great job of quantifying so that we can really sort of tackle it efficiently.
Yeah.
Now that may be also because it's probably really hard to quantify. So I'm not laying blame here. I realize that sort of thing is very complex, but and sometimes, unfortunately, I imagine, not being in a position of any government or anything, but I imagine that when it's hard to quantify a problem, it's hard to know, what to do with the resources, and it may be hard to advocate for more resources. So I think there have been like prominent politicians who have been very pro palliative care over the years, but maybe it's a hard thing to advocate for with the absence of data. Now, that unfortunately that's not a good enough excuse for the patient in front of us. So I think we do need to do better in terms of looking at the palliative care services being offered across the province and the country, and adjusting funding and provision of care accordingly.
Yeah. Yeah.
I think it was a major sort of disappointment that with all the discussions surrounding medical aid in dying, palliative care was promised in Quebec, and I believe in some other provinces as well. But in Quebec, it was very much part of the law that came into effect for medical aid in dying that there would be increased funding for palliative care services across the province. That funding, as far as I know, has not come, or has come in very small amounts. And I think that that's likely happening across the country. So we all thought, oh, great, at least we're talking about death. We're not talking about palliative care. Obviously, MAID and palliative care are distinct and separate. But at least we're talking about death and dying and suffering. And so, maybe this will be a time where palliative care will gain some funding and prominence, but that did not happen.
Yeah, that was also, I had remembered there was a moment in time when, and given everything that's happened recently, I'm hoping it was just like the context of the situation and the world being in a pandemic and everything having to kind of go on a pause. But also, that being said, I think the pandemic shed even more light on a lot of the gaps and the inequities and the lack of access to a lot of resources. And I genuinely do hope, and I guess I'm very much an optimist that we are going to start having the conversations again, and even more loudly, given everything that's happened, everything we're noticing. So yeah, I agree with you. The data isn't being researched, but I'm hoping it will start.
I'll add also that, like, when you think of the COVID pandemic and the sad sort of large number of elderly people who died of COVID, in most of those contexts, the nursing home context and different contexts where that happened, what they really needed and were lacking was palliative care. They were lacking, dignified, comfortable death in the face of the illness that obviously we couldn't cure. And I think those were the biggest scandals, the context where the basic care wasn't able to be provided. And I hope that a lesson is that actually we all provide palliative care. and whether our patients die of COVID or anything else, this is not just like a separate thing that we can let specialists do on their own. Like,
Yeah.
all healthcare providers need to be able to provide palliative care.
And I think that kind of just made me realize that maybe I didn't mention or realize, but verbally saying it, I think I need to say it for myself. Like, it's palliative care is giving the patient the ability to have dignity in the care they're providing and feel dignified as a person, and just acknowledged as being human, having the basic needs met. And it's very simple things. And I think we often think it's very complex and there's so much involved in it, but it's just treating a human how you would want it to be treated yourself, and treating each other with respect, and taking care of them and what their needs are.
Mm-hmm.
Yeah. I think my last question for this is a little more on the heavier side, I guess, emotionally, depending on how you experienced it. So feel free to answer it how you want or not answer at all. But it's really to see or to hear about your perspective and the impact of working in palliative care, whether it be more specifically during the pandemic or in general in all your years of experience, and the impact it has had on you. And has it ever led to a aspect of physician burnout? Because it is very heavy on you as a person, the workload and everything, given the lack of resources, like multifactorial.
Yeah. So in fact, about a year ago, I was experiencing burnout symptoms for much of the sort of first half of 2021. And that was the first time I had experienced that. I knew it was happening. I knew many doctors and healthcare providers were having burnout issues. I think maybe like most, I assumed that it would happen more in the worst of the pandemic, but here I was almost a year after the worst of it, and starting to have those symptoms. So that was maybe unexpected, I guess. I was listening to one of the podcasts you did about men's mental health, and I thought that was cool that they have a way to assess yourself online. I think and like that guest mentioned, when I sought medical attention for it, they also used the PHQ-9, which is what their survey was based on. And so it's a very simple survey, and it did suggest that I was having some mood issues that were beyond my usual. So what I was feeling, and the assessment sort of corroborated that. So I sought help. Psychotherapy was helpful, and medication was helpful as well. And so I would say, a year later, I am thankful in a sense that I was able to seek help. I think one of the lessons I learned from that experience was that as much as I knew about mental health issues in medicine, and in fact, when students and residents rotate at Mount Sinai, we talk about mental health issues and self-care and resilience and all that stuff. When you're actually experiencing it, some of that knowledge ends up less accessible because of what's happening in your brain. And so even though I had the knowledge, it didn't mean that I had all the tools to get out of it, because ultimately it's happening in the part of the brain that deals with emotions, not the part of the brain that has knowledge. And so like there's the limbic system versus the cortex. So like all that knowledge was in the cortex, but not in the limbic system. So it wasn't exactly the same part of the brain that would help me out. So yeah, that the other lesson I think related to that was that I think our society is fairly individualistic today versus again like 1822, where the communities aren't as tight knit, and so there's not as many people who sort of check in as on people, people, and that's sort of a lesson of like, we probably all should have people checking in on our well-being regularly, because it's possible that we're sad half the week, and we even though we thought we would reach out, when we're actually living it, we don't want to reach out. And exactly. So you need someone to sort of reach out for you and do it for you. So yeah, that community aspect of dealing with mental health, I think is something I really learned from my experience.
Thank you so much for sharing your experience. Honestly, thank you, because I think it really contributes to the need to talk about it, especially I find in medicine. We don't. We very much put it to the back burner, and having our professors, having people who are already staff coming from a student is very, very comforting, knowing that it's okay to feel the way we're feeling. Because I think obviously I never went to get it checked, but think I did have a burnout or whatever it was, given that I didn't go to get it checked and I had to kind of put everything on pause, took it a day at a time, felt extremely tired at the start of clerkship, and it was like a lot. So hearing it, that it's okay for it to happen and we're going to get better and you deal with it, and taking time for your mental health is okay, is very reassuring and I think empowering for anyone and everyone. And coming from you, I think even more so for us students and residents and everyone else who's in their training. So thank you for that.
Yeah, you're welcome. I think it's so important. Obviously, like I said, I was teaching, trying to teach what I could even before I experienced this, but all the more since I experienced it, I feel like it's like an urgent thing, and any way I can help in that area, I think is really important. And obviously, medical students, you do get a lot of sort of teaching and sort of support, but I think it could maybe even be more. So anything extra, I think helps in this area.
Yeah, amazing. Thank you so much for participating. Thank you for sharing everything you shared today. On my end, I think those are kind of all the general questions I want to go through. Is there anything you wanted to add or say to anyone who's listening?
No, well, I wanted to thank you for having this podcast and this forum for discussing really important topics, and spreading information that I think is really important. And in this era, we need to learn and grow and gain wisdom, in groups and in communities, and connect with people. And I think this interaction, gives me promise that the next generation of doctors is, not only thinking in the right ways and wanting for things to be better, but is looking for ways of communicating those lessons. So
Thank you
that's
for
really
that. That was
wonderful.
very touching. I hope so. I hope we all get to grow together, learn together. Only way we can
Mhm.
all be better.
Yeah.
Thank you again.